Welcome back to the deep dive. Today we're going deep on one of the body's most crucial balancing acts, water management.
We're looking at what happens when that system just completely fails.
Right, a condition known as polyuria-polydipsia syndrome, or PPS. And it sounds simple, drinking and urinating too much.
But it's more specific than that.
It is. Clinically, we're talking about producing more than 3 liters of dilute urine every single day. That's a huge amount, and it tells you something is seriously wrong.
And that dilute urine is the central clue. I mean, when most people hear polyuria, they immediately think diabetes mellitus.
And they're not wrong. It's the most common cause.
Absolutely. But once you rule out high blood sugar, that's when the real diagnostic challenge begins. You're left with 3 other very distinct possibilities.
Exactly. Central diabetes insipidus, nephrogenic diabetes insipidus, and primary polydipsia.
And they're all about how the body handles water, not glucose.
So our mission today is to map out the masterful clinical logic used to tell these 3 apart. Because the difference is everything. Is the failure in the brain's signal, or in the kidney's ability to even listen?
Let's start with the fundamentals then.
Okay, let's unpack the system. It all comes down to one master regulator, vasopressin.
Also known as antidiuretic hormone, or ADH. You can think of it as the water warden for the kidneys.
The water warden, I like that.
Yeah, so when your body senses your blood is getting a bit too concentrated, too salty, the pituitary gland releases ADH.
And it heads for the kidneys.
Right. It gets there and it basically unlocks these tiny channels, forcing the kidney to pull water back into the blood instead of letting it go out as urine.
So it conserves water.
It conserves water and concentrates the urine. And when that system breaks, you get our 3 diagnoses.
Okay, so let's walk through them.
First up, central diabetes insipidus, or CDI. This is a production problem. It's happening high up in the chain of command.
Meaning the pituitary gland itself.
Exactly. For whatever reason, trauma, a tumor, maybe post-surgery, the pituitary just isn't making or releasing enough ADH. It's a simple hormone deficiency.
And then the second one.
That's nephrogenic diabetes insipidus, NDI. Now, the signal is being sent just fine. The pituitary is pumping out ADH.
But the kidneys aren't listening.
The kidneys aren't listening. It's a resistance problem. The receptors on the kidney tubules, they just don't respond, so all that water just keeps flushing out.
And the third one is a whole different ballgame.
Completely different. Primary polydipsia. Here, the patient is just drinking massive volumes of water, far more than their body needs.
So this is a behavioral thing.
Sometimes it's a compulsive psychological issue or maybe a faulty thirst center in the brain. But the point is, this huge volume of water naturally suppresses ADH production.
Because the body is actively trying to get rid of all that excess fluid.
Exactly. The system is actually working as intended, but it's just completely overwhelmed by this massive external load.
And this distinction is so important. One of the sources pointed out a major clinical pearl here. Most stable patients are remarkably well compensated.
They are. They might complain about, peeing all the time and being incredibly thirsty, but they found a sort of balance.
So when you examine them, they look normal.
Pretty much. No real signs of dehydration. Their skin turgor is fine, mucous membranes are moist. It's because they're drinking constantly to keep up.
But the flip side of that, when compensation fails, that's terrifying. That's the true medical emergency.
It is. This is what happens if the person can't drink. Maybe they have an impaired level of consciousness or a damaged thirst mechanism.
Then the system just spirals.
It spirals into severe dehydration and, critically, hyperosmolality. The concentration of everything in the blood just skyrockets.
And with severe dehydration comes the risk of hypotension, shock.
And that hyperosmolality is a direct threat to the brain.
Right, the osmotic shift. Can you explain that?
Sure, think of your brain cells, your neurons, like little grapes floating in fluid. If that surrounding fluid suddenly becomes incredibly salty and concentrated,
Water's going to rush out of the cells to try and balance things out.
exactly. The brain cells literally shrivel. And that causes severe neurologic problems, irritability, confusion, seizures,
And even coma?
and even coma, which is why the very first step before any of this fancy testing is a rapid ABCDE assessment to check for stability.
So, assuming our patient is stable, we can move on to the history. We're looking for clues.
All the clues, recent neurosurgery, head trauma, are they on lithium? That's a huge red flag for nephrogenic DI. Or is there a family history?
And only then, after ruling out an emergency, do we start the diagnostic roadmap. First things first.
Rule out the obvious. A simple fingerstick glucose check. If that's normal, diabetes mellitus is off the table.
Then we need to confirm the problem is real. We need to quantify the polyuria.
Precisely. We do a 24-hour urine collection, and to meet the criteria, the output needs to be more than 50 milliliters per kilogram of body weight.
For most adults, that's what, 3, 4, maybe 5 liters a day?
At least. If it's less than that, we're probably looking at something else entirely, maybe a frequency issue, not true polyuria.
Okay, so we've confirmed the volume. Next, we need to know the quality of the urine. Is it concentrated?
That's where urine osmolality, or UOSM, comes in. Healthy, concentrated urine should be well above 800 millismoles per kilogram.
But in these patients, we'd expect it to be low.
We'd expect it to be low. If we see a UOSM less than 800, that confirms it. The urine is dilute. The kidney is failing to retain water. We are now officially in the world of DI versus primary polydipsia.
And here's where the path splits. We can sometimes get a diagnosis very quickly just by looking at their blood work.
Right. We look at their serum sodium and plasma osmolality, and this gives us path A, the early primary polydipsia diagnosis.
This is the person who's drinking so much they've diluted their own blood.
Exactly. If we see a low serum sodium, say, under 135, and a low plasma osmolality under 280, that's the smoking gun.
It's primary polydipsia. No more testing needed.
You're done. Management is fluid restriction and figuring out the underlying cause, which often means a psych consult.
Okay, so that's path A. What about path B?
Path B is the emergency we talked about. The serum sodium is high, maybe above 145, and the plasma osmolality is high, over 300. The body is severely dehydrated.
The diagnosis is DI.
The diagnosis is almost certainly DI. We don't waste time with long tests here. We move straight to the next phase to figure out which type.
But then there's path C, which you said is most patients.
The majority of stable patients, yes. Because they're compensating so well, their sodium and plasma osmolality are, well, they're normal.
So the initial labs don't tell us anything definitive.
Nothing. And that forces us to ask the ultimate question. Can the kidneys even concentrate urine if we push them to their absolute limit?
And to answer that, we need the water deprivation test.
The great differentiator. It sounds rigorous because it is. You restrict all fluid intake, sometimes for up to 17 hours.
17 hours without water. That sounds like a miserable experience for the patient.
It's tough, and they have to be monitored incredibly closely, but it's necessary. The whole idea is to force the body to release ADH.
If it can.
If it can. So, result number 1. The UOSM starts to climb. It goes up and finally gets over 800.
Which means their concentrating ability is totally intact.
It's intact. That's a definitive diagnosis of primary polydipsia. The system works, it just usually doesn't need to because they're drinking so much.
And result number 2.
The UOSM stays stubbornly low, maybe below 300. Despite hours of dehydration, the kidneys are still pumping out dilute urine.
That's our confirmation. It's diabetes insipidus.
Now we know it's DI, but we still don't know where the failure is. Is it the source or the receiver?
Which brings us to the final challenge, the desmopressin test.
The moment of truth. We give them desmopressin, a synthetic version of ADH.
So if the problem was just a lack of the hormone.
Giving them the synthetic version should fix it immediately.
So you give the desmopressin and you watch the urine osmolality.
You watch it closely, and if it shoots up, we're talking more than a 50% increase within an hour.
Then you have your answer. The kidneys were fine all along.
That's it. Definitive central DI. The brain wasn't supplying the hormone.
But if the UOSM barely moves, maybe increases by less than 50%, or not at all.
Then you know the kidneys are resistant. Even when you flood the system with the hormone, they don't respond. That's nephrogenic DI.
It's such a methodical, elegant process to isolate the exact point of failure.
It really is. And once you have that, you can move to management. For central DI, it starts with replacing what's missing.
With therapeutic desmopressin.
Right. But you have to be incredibly careful. This is where the reciprocal danger comes in.
Wait a minute. We spent the first half of this talking about the danger of hyperosmolality from water loss. If we give them desmopressin, what happens if they hold on to too much water?
That's an excellent question. It's the other side of the coin. If you over-replace the ADH, they stop peeing, hold on to too much free water, and you get the opposite problem, hyponatremia, low sodium.
And if that sodium drops too fast, it's the same osmotic problem, but in reverse. Water floods into the brain cells,
causing cerebral edema, brain swelling, which is just as catastrophic. So we monitor their sodium levels like a hawk.
And with central DI, you also have to find the underlying cause, right? A brain MRI seems essential.
Absolutely. Is it a tumor? Is it something else structural? You have to know.
Now, managing nephrogenic DI sounds much trickier. You can't just replace a hormone.
You have to get creative. First, you address any underlying electrolyte issues like high calcium or low potassium. Then you move to diet.
How does diet help a receptor that's not working?
It's about reducing the solute load. By cutting back on sodium and protein, you reduce the total amount of stuff the kidney needs to flush out.
Ah, I see. Less solute to excrete means less water is needed to carry it out.
It reduces the polyuria, even though the receptor problem is still there. Then we get to the really counterintuitive part, thiazide diuretics.
Okay, hold on. That sounds completely backward. You're giving a diuretic, a water pill, to someone who's already...
Peeing constantly. I know, it feels wrong.
So how on earth does that work?
It's a brilliant mechanism. The thiazide causes a very mild state of volume depletion. And in response, the body tries to compensate by reabsorbing more sodium and water much earlier in the kidney tubules.
Before the fluid even gets to the part of the kidney with the broken receptors.
Precisely. You're tricking the body into retaining fluid early on. It's a clever workaround.
That is clever.
Yeah.
Now let's talk diagnostics again. You mentioned that vasopressin itself is really hard to measure in the blood.
It is. It has a very short half-life. It's unstable. Measuring it directly is a lab nightmare, which is why we rely on the copeptin test. That's our technical pearl for today.
Copeptin. What is that?
When the pituitary makes ADH, it co-releases another peptide called copeptin in a 1-to-1 ratio. But copeptin is much more stable in the blood and way easier to measure.
So it's a proxy for ADH levels.
A very reliable proxy. So if copeptin is low, you assume ADH is low. That points you toward central DI or primary polydipsia.
But if copeptin is high...
It means the pituitary is screaming, it's pumping out tons of ADH, but the kidneys are ignoring it, so it's just piling up in the blood. That points you directly to nephrogenic DI. It's the ultimate tiebreaker.
Amazing. And we should briefly mention the fourth type.
Right, gestational DI. This can happen during pregnancy. The placenta produces an enzyme called vasopressinase.
Let me guess, it breaks down vasopressin.
It does. It actively destroys circulating ADH, creating a temporary state of central DI that resolves after delivery.
So to recap this incredible diagnostic journey, it starts with confirming you have excessive dilute urine.
Then you use initial labs to look for a quick answer, either severe hyperosmolar DI or a very dilute primary polydipsia.
And if the patient is stable and compensated, you move to the challenge tests.
First, the water deprivation test to separate true DI from primary polydipsia, and then the desmopressin challenge delivers the final verdict.
Pinpointing the exact failure, pituitary deficiency or kidney resistance.
And, this all brings us back to what I think is the most provocative idea here. When you really think about it, all of this complexity, the challenge tests, the counterintuitive drugs, it's all driven by preventing one thing.
Hyperosmolality.
It's not the fluid loss itself that's the primary danger. It's the resulting chemical imbalance that fundamentally threatens the integrity of the most vulnerable organ we have.
The brain.
The brain. Every single test, every drug, it all revolves around protecting the brain from that narrow, dangerous margin between too much water and too little.